Hello and welcome to Fertility Talks, the Therapie Fertility podcast. I'm your host, Ranae von Meding, and this season I'll be sitting down with none other than Medical Director of Thérapie Fertility, Dr. John Kennedy. Each week, we will be chatting all things fertility, trying to conceive, and much, much more. We hope that through this series, through honest conversations and information, we can strip away some of the stigma that sometimes comes hand in hand with infertility and fertility treatment in Ireland. This week, we are doing a deep dive into IVF and ICSI, which of course are two of the most popular and successful fertility treatments available and will make up the majority of cycles at Thérapie Fertility. So John, let's start at the very beginning. IVF.
IVF. It stands for in vitro fertilization. Vitro is in glass, so it's in a laboratory. So the fertilization happens outside the body. In vivo would be in life, inside the body. So the purpose of IVF is to maximize a woman or a couple's chance of having a baby in the minimum amount of time. It's probably, no, it is, pound for pound, the most efficient and best fertility treatment that we have out there. We know that every month you generate a whole pile of eggs and you throw them away and you recruit maybe one or two to give you a shot at fertility that month. What we're trying to do with IVF, with the medications in IVF, is get the body to produce more of those eggs that were going to be lost that month anyway. So that straight up answers one of the most common questions we get asked, which is, does doing IVF compromise my future fertility? Am I stealing from the future?
Yeah, are you taking eggs from the next cycle?
Exactly. And you're taking eggs that were going to be lost that month anyway. Okay. That's what we think.
Okay.
So you get the body to super ovulation. Instead of normal ovulation, super ovulation. You get it to produce more eggs. You then take those eggs out and you fertilize them in the laboratory. And then you grow out the resulting embryos for a number of days. We'll go into that. And then you select the best one or two, put them back in the womb. And the beauty of modern IVF is that if you have embryos left over, you can freeze them. And that gives you good shots.
So you won't have to go through the whole cycle again if you have frozen embryos.
Exactly. Yeah. So it's more efficient.
So is that why you feel so crappy sometimes on an IVF cycle? Because you're having a supercharged...
Yeah. So the ovary is usually going to be 1 to 2 centimeters in size. If you've got a very good response in an IVF cycle, the ovary could be maybe 6 centimeters.
So it's very
4
swollen.
times, and you've got 2 of them, so there's 1 on each side, so it's heavy and it's dragging and it's bloating. And additionally, we make light of it. We say the hormonal effects of the medications, they really aren't too bad. They're usually quite well tolerated. And then we throw in some kind of almost placebo line, like you might feel a little bit weepy. I do think we perhaps underrepresent some of the hormonal side effects. I think they're very variable, so it's tough to say you're going to have a really tough time with it, because you might not.
Yeah, some people do and some people don't. There's a whole spectrum of...
Exactly, but it is not uncommon, it's not desperately unusual to feel a bit crappy on the fertility medications as well. So the whole thing, and then at the far end, once you've had your fertilization and you're preparing for your transfer, you go on progesterone. Now, when people think of something like the combined oral contraceptive pill, what's in that? It's estrogen and progesterone. Now, estrogen is brilliant. Estrogen makes you feel fantastic. Estrogen is what young women have in spades, and older women, it drops off when you become menopausal. So all like skin dryness, libido, mood, all the rest are intimately linked to the amount of estrogen that's coursing around your body at any given time. So when you give somebody estrogen, they generally feel pretty good. Not always, but generally. Progesterone is a little bit the other way. All the bad side effects that you associate with the pill, the breast tenderness and the mood swings and skin acne and things like that, that's all progesterone. Yeah. So you put somebody on progesterone, which you have to for the most part in a fertility cycle, they're going to feel a little bit not so great as well.
Yeah. So we talked about IVF. What is ICSI then?
So IVF is the process where you take the egg out, you take the sperm sample, and you put each egg in a dish with about 150,000 sperm, give or take. ICSI is the process whereby you take each egg, you strip away the little outer ring of cells called the cumulus away from it, and you inject a normal looking mobile sperm into the egg.
So one.
Just the one sperm. So why might you do one rather than the other? Well, ICSI is brilliant if there's a sperm problem, if there aren't a huge number of normal looking sperm. There are clinics out there, and there was a move in the last number of years, which is kind of being pushed back on, to move all cycles to ICSI. Why wouldn't you do ICSI? You're there, you've got the eggs, why not? There is maybe some very, very limited data, and it's very controversial, that says ICSI, unless you select your cases properly, might be associated with a higher rate of chromosomal or structural problems in children. Now, that's very difficult to prove, and I do think that maybe it's not due to the ICSI, it's due to the need for the ICSI.
Okay.
So if you've got people with severe sperm problems that you have to do ICSI on, maybe they're more likely, in fact, it's probably fair to say they are slightly more likely to have a child with a problem than not. And so you're seeing a higher incidence of those things in cases where you do ICSI. Sometimes, very rarely, it's about 1 in 1,000 cases. You put the eggs and the sperm in the dish together, and you come back the next day and fertilization hasn't happened. They haven't stuck together at all.
So nothing's happened, no embryos.
Yeah. And we know there are some genetic causes behind that, but you also know it can happen for reasons we don't fully understand. That's what's called no binding. And in those cases, you say, right, we should do ICSI next time. And every time, it's really unfortunate, you have that conversation, the question you're immediately asked is, why the hell didn't you do ICSI the first time if that's a risk? Because it's 1 in 1,000. And you're manipulating eggs and you're manipulating sperm more when you do ICSI than when you do IVF. I don't really like that word natural, because I think there's nothing really natural about what we're doing here at all. But IVF is a more natural way of fertilization than ICSI. ICSI is more process, it's more involvement. And with process involvement, no matter how careful and good you are, comes risk.
Yeah.
So I prefer not to do it than to do it. That being said, most modern clinics would be about a 50-50 split on ICSI IVF. And what we tend to do is if we look at the sperm on the day that we collect the eggs, or if we know in advance there's a problem with the sperm, think, look, do you know what? We think the fertilization might take a bit of a hit if we don't do ICSI. We really should. We should have a low threshold for doing ICSI because we think it's very, very safe. We think it's very, very effective. But when all things are ideal and equal, you do it.
You'll go with IVF. And I suppose, it is a little bit more natural because it's, in essence, allowing natural selection to an extent, seeing which...
So, for example, with something like the reciprocal IVF program or the shared motherhood program, that sperm that's being used will all be donor sperm.
Yeah.
So automatically... it's
going to be excellent sperm.
It's going to be IVF.
Yeah.
It's not going to be ICSI unless there's some grandiose reason that somebody had no binding before or some weird edge case. Yeah. It's going to be IVF.
Or on the day when you come to it, you're saying, hang on, we need to do ICSI here.
Absolutely. We call the sperm and we're shocked because it doesn't look like it. And that's rare sense teeth, thankfully. But then, yes, you could transition. But by and large, 99.9% are going to be IVF. Okay,
so the majority of people coming through Therapy Fertility are going to be having either IVF or ICSI.
Yes.
People are also going to be having IUI.
Yes.
Which, let's just talk about that very briefly.
Yeah. So the very brief Cliff Notes version is turkey basting. IUI is intrauterine insemination. It's the process of giving somebody some medication so they'll recruit 1 or 2 eggs, no more than that, triggering the release of those eggs. And when we know those eggs are being released, taking a sperm sample, be it a partner sample or a donor sample, washing it, preparing it, and putting it in at the top of the womb, shortening the journey the sperm has to make to get to the egg.
So it's not something that people can actually do at home because it is...
You can, and there are home insemination kits. When we do an IUI, we pass a small tube catheter right into the top of the womb.
Yeah.
When you do it at home, you generally pass it into the vagina or into the tip of the cervix.
Yeah.
So we're adding more of a shortcut.
Yeah.
And we're being much more metric in terms of the timing and the release of the eggs and the stimulation.
And you're also washing the sperm. And
we're also washing and validating the sperm. And we know that certainly in the case of donor sperm, it's coming from a reliable source where the person's been screened psychologically and HIV and hepatitis and genetically.
So what are, I know people like to talk about success rates, but what, if you're looking at, someone coming in and wanting to do IUI versus an IVF cycle, what's the difference?
So I've been talking a fair bit to the team about this recently, and I'm going to declare a bias. I think IUI has its place, and I'm going to talk about cases where I think IUI is a very good idea. But speaking as somebody who is working in an IVF clinic, I have a bias towards IVF. We do IUI. I think the advantages that IUI brings to the table is that it is simpler and easier and cheaper than IVF. When I say cheaper, it is financially cheaper. It's physically a little bit cheaper because there's less involved in it, but I'll break that down a little bit more. And it's emotionally and psychologically a little bit cheaper because it doesn't have quite the same level of stress associated with it if it doesn't work.
Yeah, because
typically, because it's not anticipated to work as well.
Yeah, a lot of people are like, okay, we're going to do this a couple of months and see how it goes. Yeah,
exactly. So it does have some things going for it. What does it have against it? Well, financially, it's cheaper, but it's probably substantially less successful. As a general rule of thumb, and this doesn't apply to everybody, 1 IVF is equal to 3 IUIs, give or take. Maybe 1 IVF is a little bit better than 3 IUIs. So you need to go through 3 IUIs to do 1 IVF. And when you look at the cost of IUI versus the cost of IVF, that narrows the financial gain that you're making a lot. Physically, sure, it's easier, but you're still taking injections, you're still taking tablets, you're still attending for a scan, you're still coming in for a procedure. So in real terms, it's probably as much hassle and impact on your day-to-day life as IVF is.
And you don't get the chance to freeze any embryos.
Aha.
I just thought of that.
Emotionally and psychologically, easier, but IVF is a test as well as a treatment. The one thing we really don't know before when we do all our testing, we check your AMH, and we look at your antral follicle count, we try to guess how many eggs we're going to get, we can never speak to egg quality. We just can't do it. We can speak to sperm quality, but not to egg quality because we're not looking at the eggs. When you do IVF, you take eggs out and you make embryos with them, and that is a test of those eggs. Now, if I only look at 10 eggs, it's hard for me to make sweeping judgments about all your eggs based on that, but I get a flavour, I get an idea, and as we build more, do more cycles and get more eggs, you build up a clearer and clearer picture of that person's egg quality. So functionally, you learn an awful lot more from an IVF cycle. Win, lose or draw, you learn. There's huge learnings. It's a huge diagnostic test. That's not why we do it. We do it to get babies, but that's one of the secondary gains. With IUI, you learn virtually nothing.
Because if it doesn't work, it doesn't work, and you don't necessarily...
If it works, boolabus more, big round of applause, we're all delighted.
Yeah.
If it doesn't work, it's as if you didn't do it at all.
Yeah.
You don't know, was an egg released? You don't know, did the sperm meet the egg? Did fertilization happen? Did the embryo develop? Did implantation? You don't know any of this stuff. And so, and this is what you really need to get across to people at the start, negative IUI is not so much associated with disappointment as it is with frustration. Yeah, it's frustrating.
Because you don't know.
And you feel...
And you're spending money.
And you've got nowhere, you've learned nothing, you've wasted time, you've wasted money. Now, if you have this conversation before they start the IUI, it's a hell of a lot easier.
Yeah.
Because people are prepared and they're making an informed choice, and that's great. But if you don't, they generally, people who've done a few IUIs and it hasn't worked, you ask them, they'll tell you they wish they hadn't done them.
Yeah.
Well, not all of them, but some.
Yeah.
Whereas somebody who's done IVF, they're generally okay with the fact they've done IVF even if it hasn't worked because they've learned a lot, they've got to different points and different parts of the journey. But IUI tends to lead on to IVF.
Yeah, I know a lot of people who have done IUI.
So who does IUI? Well, because it's pitched as being a more natural way of doing things, same-sex couples and single women tend to veer towards IUI at the outset. And I can see why. It makes a lot of sense. It looks better. If you're young and you're healthy, you've got maybe a 17 to 20% chance of a positive pregnancy test with 1 IUI. It's not terrible. So it racks up. And so it's a very reasonable thing to do. But, and this is where my bias kicks in, coming into a fertility clinic with fertility issues, wanting to get pregnant, be it because of a sexual orientation or being a lesbian or because you're not in a relationship or because you're struggling to conceive, it's tough. It's a tough thing to do. My belief is the less time you spend engaged with fertility services, the better off your life is.
Yeah.
You know, I like you too, but the less time you spend, the better off you are. So I prefer people to come in, hit the ground hard, do the thing that's more likely to result in a baby in a shorter period of time, and get the hell out.
That seems pretty reasonable to me.
But that involves more medicalization, more medicine, more initial outlay, tougher emotional and psychological costs. But I'm funneling it all down to a tighter focus. That being said, if somebody wants to do IUI and they're a good candidate, we won't fall out over it.
Absolutely. And yeah, like plenty of babies are born through IUI, and plenty of people are very happy with their,
100%. It's a perfectly cromulent, it's a perfectly acceptable fertility option.
I suppose it's just when it doesn't work. And when it doesn't work, cycle after cycle, and then you end up going to IVF and and then you're like, Jesus, I wish I had done this in the first place.
In countries where there is public funding services, a lot of the times they'll make you do a number of IUIs before they'll fund IVF. And that's sort of normalised, perhaps incorrectly normalised thing. Oh, you should fail IUI before you do IVF. Yeah. Whereas I want to take IVF out of that dark corner and bring it up and go, no, listen, let's just, rather than have this woman engage with health services for a year, let's have her engage with health services for 6 months. Yeah. Because honestly, if you're just looking purely from a public service point of view, there's a lot of savings in that as well. Yeah. Get them in, get them out,
Totally. So let's go back to IVF and ICSI. Yep. How long should someone wait? Now we're talking about heterosexual couples who are having unprotected intercourse. Like, how long should someone wait before they are talking to someone like you or accessing help?
World Health Organization has advice on this. It says if you're trying over a year, if you're under 35, over 6 months if you're over 35, then seek assistance, seek information. That's because you turn into a pumpkin.
On the eve.
Exactly. So that's a pretty artificial thing. I think they're reasonable metrics to look at. You can start getting tested, but I would be an advocate of earlier testing. I like the idea of a 28-year-old couple who are thinking about getting married, her getting an AMH checked and him getting a semen analysis done.
Well, it's so simple as well, isn't it?
Yeah. So I personally would like to flip all of that on its head and to say, do you know what? Maybe you don't have to run into problems before you seek help. And seeking help, getting information does not necessarily mean doing fertility treatment.
Getting fertility testing doesn't mean you're ever going to get fertility treatment.
Because the accusation is, oh, he just wants to get them in. He just wants to do IVF. And no, I don't. I just want you to know. And then off you go. Because if you're 35 years old, 34 years old, and you've been trying for a year and you haven't gotten pregnant, that's a lot easier if you know your AMH is normal and there's no panic. You know the semen analysis is normal. You know the tubes are open. You know the other baseline bloods are okay. That should be reassuring. We know that average conception rate's about 17% per month under ideal circumstances. We know that 90% of couples will conceive within 1 year, 95% within 2 years. So somebody is just going to be in that position for no other reason than just dumb bad luck. Now, does that person need IVF? Well, that's an interesting question. If you talk to somebody who's publicly providing a service, the answer is, generally speaking, no, they don't. They'll get pregnant themselves. But personally speaking, I like that person to have a choice and go, you know what? You can keep trying, and in another 6 months, you've got a pretty good shot. Looking at the dice on the table, you've got a pretty good shot at getting pregnant. Or I can up your odds, but it's effort, it's cost, it's time, and it's either IUI or IVF or something else. And the sooner people get all that information about their own potential, their own fertility chances, and they get information about what their options are, the timelines and the chances associated with those options, then whatever they decide to do is the right thing to do. Yeah. So, oh no, you can't come in for testing. You've only been trying for 3 months. No, come in for testing.
At any stage.
At any stage. Yeah. And I've had people where I've said to them, look, you've only been trying for 3 or 4 months. Give yourself some time, take a step back, relax. And the vast majority of people obviously just take that advice and go, listen, we're going to keep trying ourselves. And in 3 months, if nothing's happened, we'll give you a shout and we're already in the system. We've already had the testing done and it'll be much faster. And I go, great idea. Some people go, no, I want to focus on this. I've got time-sensitive things coming up. And it's very important you explain to those people that even what you're doing, there's no guarantee of success. All you're doing is changing the odds a lot, but changing the odds. And it's up to them. It's not my time and effort. Yeah. There's a bit of it, but I'm being compensated for that. That's the point of the service. It's their time and effort that I want to be respectful of. Yeah. And the job is to make sure they understand the limitations and the opportunities that we can bring.
So there's obviously some circumstances where people would be advised to seek help sooner. So, well, I mean, obviously same-sex couples, single people coming in, but are there any like medical conditions or other circumstances where people just are going to need fertility assistance?
Sure, yeah. I mean, there's people, if you've had a surgery and you've had an ovary removed, obviously that's the thing. If you've had a history of undescended testes, then it's maybe more likely that there's a problem with the sperm. If one thing that tends to get missed, like a cancer diagnosis, which is, that kind of thing. But one thing that tends to get missed a little bit is family histories. If you've got a family history of subfertility or infertility, and it's the really bad dad joke that having children is hereditary. If your parents didn't have any kids, chances are you won't either. But infertility issues do tend to run generationally. Historically, earlier menopause, lower ovarian reserves do have a genetic component to them. So if your mother and your sisters struggled, then it's a good idea for that to be on your radar. Equally, if you've got a family history of something like endometriosis, that's a good idea. It should be on your radar and should be ticking along. But I'd like to normalize that for everybody, because all I'm doing is really trying to identify risk groups when I could just identify everybody, and it's about prevention rather than problem, and identifying issues earlier works out better. So I think if you've got a family history of endometriosis, if you've got a history of surgeries, if you are worried if other people in your family, or if you have friends, and I know there's no genetic link between your friend needing IVF, but that's an opportunity for somebody to go,
to be conscious of it,
be conscious, get checked.
Okay, so another couple of questions about like the IVF ICSI process. There are embryo transfers. What are all those different stages of embryo development, and why would you transfer, at certain stages?
So here's where the podcast medium lets us down a little bit, because I would often start drawing things out on a piece of paper, but I'm going to try to describe it as best I can. So you collect the eggs, you put the eggs and sperm together, and they fertilize. Not all the eggs will be mature, not all the eggs will fertilize. You then check them on day 1, day 2, day 3, day 4, day 5. On day 1, they're 2-cell embryos. On day 2, they're 4-cell embryos. On day 3, they're 8 to 10-cell embryos. On day 4, they jump from being an 8-cell embryo to what's called a compacting morula, a loosely bound collection of about 100 cells or so.
So there's massive growth on that day.
It's got proliferation. It goes boof. And then day 4 to day 5, give or take, they turn into what's called a blastocyst. A blastocyst has a ring of cells around the outside of the embryo that's going to form the placenta and the membranes. It's called the trophoectoderm. And it's got an inner cell mass that's going to form the baby. So that's when you look at the little diagrams online, you see that rapidly, and then the pictures start to change on day 4 and day 5. You look at that and you realize that the steps between day 1 and day 3 are relatively simple. All the embryo is being asked to do is all the cells are being asked to do or become themselves again. Mitosis, just divide. Day 4, they're dividing much more rapidly. That's called proliferation. So there's more and more parts of the blueprint, the genome, being accessed to make that change happen. And then day 4 to 5, you're getting proliferation and differentiation. So cells are becoming different kinds of cells.
Sure.
And that's even more complex. So more and more parts of the genetic pattern are being accessed again at that stage. So embryos should, in the main, be able to make it to day 3. And we would anticipate maybe 60, 70% of all, maybe even more of day 1 embryos will make it to day 3 easily. So you can put an embryo back in on day 3, but you've got 5 or 6 embryos, say, in front of you, and you don't know which is the good one. They all look pretty good. None of them have been particularly challenged. So a lot of those embryos won't make it to day 5 and certainly won't become a baby, but you don't really know which ones. So if you put it back in, it's a little bit more of a lucky dip. And I had an old colleague who used to say day 3 embryos are little liars.
Because on day 4 and day 5, things could go horribly.
They might collapse. So putting an embryo back in on day 3 it's still the same embryo as it would be on day 5. Okay? Putting an embryo back in on day 3, I think, is a chancier proposition.
Because you don't have the information of what's going to happen.
As much information. Yeah. Exactly correct. So I like to go out to day 5. Now, on day 5, you're going to have less embryos.
Yeah.
Less than half of our day 1 embryos make it to day 5. And even on day 5, depending on your age and circumstances, half of the good-looking embryos on day 5 probably won't give you a baby.
Yeah.
But it's still a higher shot. So I like to go out to day 5. So how did we ever get into this situation? Why wouldn't day 5 be normalised? Because day 5, I mean, it's a newer phenomenon, and IVF has been around for, God knows, more than 20 years maybe at this point, but it's still new. It used to be that it was more problematic to grow embryos in the lab to day 5, that it was less controlled, and maybe there was a risk to the embryos in those extra 2 days. That's gone by the wayside now. With time-lapse machines, the embryoscope with the little machine that the embryo sits in, it's a very secure environment. I do not believe at all that the lab is a worse environment than the womb. Yeah. The other thing that we get told is, well, you're putting the embryo back in on day 3, back into its natural environment, which is the best environment for it. I was like, no, you're not. The natural environment for a day 3 embryo is not the uterus, it's the tube.
Yeah.
It's still, so you're not, which has a slightly different physiological makeup. Now, I'm not saying putting a day 3 embryo back in is a bad idea for the embryo. It's perfectly fine. We've got loads of data on that, but it's not better. So you're not fooling yourself. But of course, what I do, or what most modern fertility clinics do at this point in taking everybody out to blastocyst before doing a transfer, is risking the fact that by day 5, you will have no embryos to transfer. Yeah. And that's devastating.
Yeah.
But it's not worse than putting an embryo back in on day 3, inflicting a 2-week wait on the woman and the couple.
And then it doesn't work anyway.
And then it doesn't work. And you've lost the information.
Yeah, because at least if you grew out to day 5, you'd know something was happening at day 4. Yeah.
And you can use that, and that goes back to the diagnostic thing we were talking about. You'd be able to use that to advance the conversation, to direct and go, look, this is where the issue is, this is the solution, and so on and so forth. So I'm a big fan of day 5, have been for a long, long time. And I personally believe day 3 transfers and freezes shouldn't really be done anymore. I think they've gone out with the arc, and I've seen people, and it's falling away now, but I saw plenty of people with, right, you only have a very limited number of embryos on day 3. Let's do a transfer now. Because that way I can say I've done a transfer, you've had a transfer, everybody's feeling pretty good for the next 2 weeks. I think that's just an agreed lie.
Yeah.
And I don't personally buy into any statistic, and I've looked at the data on this, where it goes, oh no, you're more likely to have a baby with a day 3 transfer. I don't think that's the case.
Yeah. I personally would think it's a lot worse to go through the 2 weeks hoping that something has worked, rather than just, having that conversation.
And everybody's different, and some people just really want that transfer. What I do find is that you really need to have this conversation before the cycle starts.
Yeah.
If you haven't explained the logic and what you're trying to do, if you get to day 2, say, and there's only 1 embryo there, and you haven't had the conversation,
of course, you're just like, please just do anything.
And you can't have a rational conversation at that point.
Yeah.
Which is not to say they're irrational, but you can't have
you're like completely in the middle of it.
Exactly.
Yeah.
So it's very important to get that across the line at the start. Or to say, listen, we are an organisation that has your best interests at heart. We believe that the best way to do it is this way, so that's what we're going to do.
Yeah.
Pure and simple.
Are there any potential side effects to doing IVF and ICSI?
Yeah, there are. I mean, look, there's risks. As I said earlier, you're growing the embryos, and rather like a very swollen apple on a tree, it can twist and cut off its own blood supply, and that's called torsion. That's very rare.
Sorry, the eggs.
Risks to the eggs of...
Yeah, so are there any risks to, a person going through the fertility medication and growing all these eggs?
Sure, absolutely. And are you more likely to get a bad egg out of the system? And are you more likely...
Yeah,
so that's
and like hyperstimulation and,
exactly.
That sort of thing.
So that's a pretty controversial one. All the fertility scientists and the doctors and lab staff working in fertility will go, the evidence does not suggest there is any issue with compromised eggs as a result of IVF and ICSI. And people who don't work in the field at all will go, there is an increased incidence of babies being born with chromosomal and structural problems as a result of IVF and ICSI. And then the fertility specialist will go, yeah, but that's not the IVF and the ICSI's fault. That's because we're dealing with infertility and struggling couples, and there's other problems going on, some of which we know, some of which we don't, which is contributing to the increased chromosomal and structural problem. It's not our fault, we're part of the solution, not the problem. And it goes back and forth in that fashion all the time. The truth probably lies somewhere in the middle. I do think that if you hyperstimulate and you push and push and push the ovaries to get a huge number of eggs, you start to see compromise in the eggs. Now, does that mean you're also compromising the first eggs that you would have got with a lower dose of stimulation anyway? Suppose I can give a low dose and I can get 10 eggs. I can give a higher dose and get 20 eggs. I already know that I'm less likely to get a baby from eggs 11 to 20 than I am from eggs 1 to 10. But by getting 20 eggs, I'm not compromising eggs 1 to 10.
Okay.
And I'm increasing my overall chance. Fine, I'm starting to run into the law of diminishing returns, but more eggs still means more embryos, still means higher chance of baby, albeit at a lower rate. Now, the most recent data, I think, suggests that once you go over 32 or 34 eggs, which would be very unusual in any given cycle, you start to see a compromise in the quality, in the quality of everything potentially, you know? So you definitely, it's never a case of, I just want to turn the amp up to 11, I just want to dial it all up, but I want to push as hard as I can and get as many eggs as I can. You need to be more restrained than that. The trend across recent years has been to get more eggs, and more eggs equals more embryos, but there is a limit on that.
Yeah. And
you can push too hard, and one of the things we try to do. So that's why, and it's something we have a lot of conversation with patients about, well, why don't you just give me more of the fertility drugs? Just give me more, you know, and more, because you'll hit a law of diminishing returns, you'll saturate the receptors, the FSH receptors. You won't get many more eggs in most cases, and in those cases where you can get more eggs, it's a bad idea.
Yeah.
There's depending on who you talk to, what's the optimal number of eggs in a given cycle? And it's impossible to answer. A lot of embryologists will tell you, it's about 14 or 15 or 16. Don't really want more than that. But when I've looked at internal audits in clinics I've worked in, it's kind of, well, actually, you know what, 22, 23, 24 isn't bad. Now, most people can't get 22, 23, 24 eggs in a cycle. But when you can, it's maybe not terrible. And we tend to get ruled, and this is terrible, we tend to get ruled not by the data and the audit and the overall, to get ruled by the last time that happened and what happened in that one. You know, well, I remember that time and I got 25 eggs and she had a baby and she's got 12 embryos frozen and her fertility locked in forever. It's fantastic. Versus, she had 25 eggs and none of them were mature and none of them fertilized, and really that's changing my mind now. You need to not do that. You need to, so if you're working in a clinic, you're working in an organization, you need to be constantly auditing all those KPIs. You need to be constantly looking at what dosages are we using? How many follicles are we getting? How many eggs is that turning into? How many of them are mature? How many are getting to blastocyst? How many are giving pregnancies? How many are giving babies? And you need to know that, because while the person sitting across from you as a patient is an individual and you treat them as an individual, you need to be able to bring the power of your knowledge, what you've done and what you can do, to the table and go, the data supports in you, I know you're a special unique snowflake, but in you, a 32-year-old woman with an AMH of 20 supports doing this.
Yeah.
But if you give me a higher dose, I get more eggs, possibly, but the data supports doing this.
And it's like it's the overall picture. Exactly. It's not just about how many eggs you get, it's that whole process and the end result, which essentially is what someone wants, a baby.
Exactly. And sometimes you get lucky and sometimes you get unlucky. Sometimes you do an optimal cycle, you've got great embryos, you've got no baby. Sometimes you do a cycle that kind of goes a bit sideways, that doesn't, then you kind of fall through the stages a little bit, and at the end you get a baby out of it, and that's a win. Now that doesn't necessarily mean you should go for a suboptimal cycle the next time because it gave you a baby the last time, although try telling people that. But it does mean you just have to be objective, and you have to be clear about why you're structured, why you're doing something one way or the other.
Yeah. So you kind of answered one of my questions, was, will I lose eggs faster?
Yeah.
So no, essentially.
No is the short answer on that, I think. I suppose I'm open to my mind being changed on that if data emerges, but it doesn't appear to be. And the other question we get asked a lot, because you're giving stimulation medications, you're pushing ovaries and you're kicking up somebody's estrogen, are we increasing risks of breast cancer, ovarian cancer, endometrial cancer? It does not appear that we are. Which is great, and there's pretty strong data on that at this point as well, so that's encouraging.
My last question is, how long is the process? Because that's, and I know how long is a piece of string, but like, say if someone came to therapy and had their nurse consultation, had some testing done, had a consultation with you, came up with a treatment plan, how long from that initial nurse consultation to potentially becoming pregnant?
Let's pretend you come into us, it's 1st of September, for argument's sake. I'm just picking data out of the sky. You see a nurse in early September, You have some testing done that month. You see me in the second half of September and you go, right, I really want to do IVF as quickly as I can. Realistically, what would probably happen, and it will, obviously there's massive variables here, it would be reasonable to think that if you were still 7 days away from your next period, that you could get started on stimulation medications with your next period. So that would probably be early October-ish, you know?
Yep.
So you'd be on some meds before that, but let's not worry about that for a minute. You'd start on your stimulation medications with the period, give or take. You take them for about 10 to 12 to 14 days, 10 to 12 days probably. Then you'd have an egg collection 2 days after that. And then you might have an embryo transfer 5 or 6 days after that. And then a pregnancy test 12 days after that. So that would be kind of mid-November.
So not too long,
No.
really.
Now, sometimes we might have to freeze all the embryos. And that would add 3 weeks onto that time frame, because you freeze the embryos and then start a slightly different process.
Here's a question. Why would you be freezing the embryos?
So many different reasons. So we would anticipate that we're going to have a freeze-all rate probably around 40%, I think.
And freeze-all just means that you go through the collection, the fertilization, you have embryos, and then you freeze everything.
So why might you freeze them? The 2 big reasons that we would freeze in a normal routine cycle is that a scan or a blood test had indicated to us that the womb wasn't in an optimal condition for an embryo transfer. Your progesterone might be high, the lining might not look so good. So in that case, you're way better off freezing.
Because you might lose embryos into a suboptimal kind of condition or whatever.
Absolutely. The other reason is that you might be teetering around the fringes of ovarian hyperstimulation. Now, we'll get into ovarian hyperstimulation another day, but suffice to say that it's a condition whereby you move from controlled stimulation of the ovaries to a slightly uncontrolled situation, and that can have serious health implications. That can have implications for your fertility health, for your general health. So it can be a big deal. The one thing that feeds hyperstimulation more than anything else is pregnancy. So if somebody's teetering around the fringes and you do an embryo transfer and they get pregnant, they're far more likely to flip into full-blown moderate or severe hyperstimulation, perhaps wind up being bedbound or in hospital or something worse. So you really want to avoid that. Now, in the past, when we froze embryos, we would lose about a third of them whenever we thawed them. So anytime you did a freeze instead of a transfer, you were thinking in your head, I'm subtracting 30% overall from the success rate. So I've got to balance that against the risk. Like, the lining looks suboptimal. Okay. Does it look 30% suboptimal?
Yeah.
Okay.
Yeah. And it becomes a math
There's
question.
a risk. Yeah. There's a risk to the woman. How bad is the risk? Well, there's a 30% chance she'll die. Okay, fine. We're not going to do that. Okay, there's a 1% chance she might wind up in hospital. Ooh, geez. Now we're into,
Yeah.
And so it was a much more of a balancing act. With newer freezing techniques, the freeze survival rate, 97, 98, 99%.
That's amazing.
So
yeah,
it's really safe to freeze embryos. And as a result, we're freezing more and more. Finally, there is a school of thought that says frozen embryo transfers work better than fresh transfers. That even when the lining looks good and the bloods are fine, the act of stimulating the ovaries has a negative impact on the lining of the womb. And so all cycles should be freeze-all cycles. Now, that is controversial data. So I think it's not strong enough now. I think if things look really optimal and absolutely fine and the risks are low, it is reasonable to proceed with a fresh transfer. But at the slightest sniff or hint of a problem, you should freeze. And that's where most clinics are falling at the moment. Some clinics have moved into a freeze-all strategy. So as a general rule of thumb, they freeze everything. And that's fine. I think it's a perfectly reasonable medical approach. I don't have a problem with it. It's slightly easier logistically for the clinic or the organization to run a freeze-all strategy because you can be much more organized about your workflow and your process and how you manage the patients. So I'm always just slightly wary, and perhaps I'm being a bit cynical here, but I'm slightly wary of data that supports what the field wants to do anyway, right? Because you get a lot more buy-in. But right now, I feel very, very strongly that freezing is not a bad thing. I'm not quite at the freeze-all stage, but I reserve the right to change my mind pending pending data coming out, and I do know plenty of people who are very wedded to the notion, and they're very smart people, a lot smarter than I am, and so maybe they're onto something, and it's something that we need to keep a close eye on. For example, with the reciprocal IVF program, it'll all be frozen. We're freezing everything. We're not doing any fresh transfers.
Yeah, because otherwise you're trying to sync up two people's cycle, and
which isn't impossible. It's very manageable, but I am putting somebody on medications for a transfer that might never happen.
Yeah, because so if you end up with embryos and one partner has gone through the egg collection, you have these beautiful embryos, and the other partner, for whatever reason, levels are off, thyroid is high, something could happen. Exactly,
and I can very capably hide behind the data and say, look, this is a perfectly safe thing to do. This is a normal thing to do in an awful lot of centres. So it's great that we have that resource drawn now, and it could be in the future we'll freeze everything, but maybe in 20 years time, even there's some data, we just don't know. So I mean, obviously this is an ongoing thing. It seems to be a really safe, really effective way of managing things, and so you really should, if you're in your own side, be guided by the clinical circumstance, be guided by the team who are minding you, and take their advice.
Well, I'll come back to you in 10 years on that, because one of my kids is a fresh and the other is a frozen. So
I love that. That's two. That's enough. That's enough data. We can close the book when we look at those two. We'll look at their junior cert scores or whatever it is, and we'll let the Lancet know.
Final question. This is more of a fun one. Do you tend to get patients who test before the 12 days?
Or
do people come in and lie to you and say, "Oh no, I didn't do an at-home test"?
I would say 90% do. I would say 10% tell me. So I think, look, so I'm blue in the face on this. Don't test early. You're not going to help yourself. You're only going to give yourself anxiety. You're only going to worry yourself.
You might get a false positive. You might get a false negative.
Left over from the HCG injection. You might get a false negative because it hasn't kicked into the system yet. I'm not saying it's entirely without value either, because when I say, it's entirely without value, but I can see that there's some value in it, and I can see why people do it, and I'm not going to be able to stop it. But if you are going to do that, just go for it, I guess. I don't think it's a brilliant idea. But please, please, please don't get too wedded to the result.
Yeah.
I'm not going to get wedded to the result, and what everybody's going to tell you. They're going to say, we need a blood test, and we need it done at the appropriate time, and that's the only way we can tell. Sure, if you come into me and you come into me on day 12 for your blood test, I tested 5 days ago, it was negative. I tested 6 days ago, it was negative. I tested 7 days. Yes, that is going to make me more guarded, in my opinion, about what this blood test is going to show. It is much more likely to be negative than positive.
But it could still be positive.
It could still be positive. Blood is thicker than water. It's more reliable than urine. We know all of these things. We know there's other factors involved. So, I mean, everybody. It's very hard not to. I know if it was me, I'd struggle to not test.
We 100% did. 100%.
Now, did you tell the people that you did?
No.
There we are. So,
No.
And so the world turns.
Actually, do you know what? The second time, so we had like an early loss with our first transfer, and then we had a second frozen transfer. And I actually didn't tell my wife that I was testing, because I was just so afraid that it was not going to be successful. And I got one of the digital ones, and I did it like really early in the morning. It was a Saturday morning, never forget it. And I snuck off, didn't tell her, and I did it, and it came up as, it just said pregnant, and I just ran in, and she knew, she saw my face, and she knew. She's like, "Did you test?"
There we are.
And I was like, "Yes."
And the most unusual part of that story is that you said you only bought one.
I know, but they're expensive.
Oh, I know. They're putting you're putting some companies' kids through college. I mean, like, nobody ever buys one pregnancy test. That's the most unusual part.
We bought loads of the cheap ones, but the digital ones are like pricey, right? Yeah.
Yeah, I bought 10 Duff ones, and I don't trust them, so now I'm back out to the pharmacy.
Actually, for the second child, I think I bought some in deals. That's just standard second child.
And you're saying the difference between fresh and frozen embryos? Sure, yeah. I think we're the writing's on the wall.